Yeah, it's a great pleasure to have Sriram Pemmaraju join us for this seminar. Sriram is a professor in the Department of Computer Science at the University of Iowa, and we've been working together on many different problems for a long time. His research interests are in algorithms, distributed computing, and applying algorithmic ideas to computational epidemiology, especially understanding the role of space and architecture in the spread of HAIs in healthcare facilities. And we've used a lot of his ideas and models in our own work and HAIs on the UVA hospital. So, Sriram, looking forward to your talk.
All right. Yeah. Thank you, Anil, for that kind introduction. And thanks to Madhav and Anil for inviting me for this seminar series. So in this talk, I'll describe some 10 plus years of research effort at the University of Iowa to use computational methods to understand and mitigate the spread of healthcare infections. Consider this rather unfortunate scenario where an elderly patient is admitted to a hospital for a hip replacement. After surgery, the patient is prescribed antibiotics, presumably to prevent surgical site infections. But antibiotics, in this case, reduce good bacteria in the patient's gut microbiome, making her susceptible to a variety of infections. And the patient is also in an environment where C. diff spores are quite prevalent. And because of various interactions that this patient has with healthcare professionals, she's exposed to C. diff at a time when she's particularly vulnerable, and she ends up acquiring C. diff infection. This may, of course, be detected while she's in the hospital, or it may be detected when she's gone home, in which case it might imply a readmission. Here is a poster from the CDC on the progression of C. diff infection. And as you can see from this poster, C. diff can cause fairly severe diarrhea and colitis, inflammation of the colon. And elderly patients are particularly susceptible to C. diff, and antibiotics are a big risk factor for C. diff and so on. But beyond C. diff, healthcare-associated infections in general impact about 2 million patients per year in US hospitals, leading to about 75,000 deaths. And they impose a significant burden, of course, on the patients themselves, but also on the healthcare system in general. And I've talked about CDI, C. diff infections, but other examples of common HAIs include MRSA and CRE and VRE. And these other infections that I just mentioned, they all are resistant to different kinds of drugs. So these are the HAIs that are of particular concern. And beyond these HAIs, even infections that one thinks of as community-based infections tend to get amplified in healthcare settings. So in a sense, they can also be viewed as HAIs. This, of course, includes COVID-19, hepatitis, influenza, TB, and so on. And we saw this a lot with COVID-19 in the early days of 2020, I guess, when long-term care facilities is where COVID outbreaks initially happened in the US. And in fact, I was just reading this article in the Washington Post, I guess 3 days ago, where they're talking about Candida aureus, this fungal infection that's spreading in healthcare facilities. And I guess fungal infections were somewhat overlooked relative to infections caused by viruses and bacteria, but especially because of COVID-19. But fungi tend to be pretty hard to clean from surfaces, and they're long-lasting. So this is definitely an issue that healthcare facilities are thinking about right now. So this was a brief introduction to HAIs and what they are and why we're interested in trying to understand their spread and try to figure out how to mitigate them. I now want to kind of switch focus a little bit and talk a little bit about the Computational Epidemiology Research Group at Iowa. It contains a few people in computer science, but it also contains people in internal medicine, epidemiology, biostatistics, and from other departments also. And we apply a variety of tools and techniques to think about HAI-related problems. But one, I guess, key theme that I want to emphasize, and I guess it's a theme that characterizes our work, is that we pay a lot of attention to space and architecture and how it impacts the flow of patient care, and therefore how it impacts disease spread in general within healthcare settings. So moreover, we perform these studies at different spatial resolutions as appropriate for the problem. Space, of course, has been important part of epidemiology, at least from, I guess, the time of John Snow's investigation of the Broad Street bump in 1854. But we think space is also important, maybe especially important in healthcare settings because of how profoundly it impacts patient care. And I guess one last point I want to make is that while there are fairly mature tools and techniques for spatial epidemiology in general, this tends not to be the case for the setting we are focused on, namely healthcare facilities. And as examples of this theme, I want to briefly mention 4 studies. And for each of these studies, I have a little picture to show you what it's about. So the picture on the left is a study that we, I think, completed in 2018. And this is trying to understand how healthcare workers who enter a patient room, what sort of surfaces do they touch? How long are these touches for? How do they correlate with the time that a healthcare worker spends in a patient room, things like that. And in order to get this data, we used a couple of Microsoft Kinect cameras in medical intensive care unit patient room. And this picture here shows a heat map of where the hands of healthcare professionals are when they are caring for a patient. In the study on the right, we are moving up one scale in spatial resolution. So here we are thinking about a hemodialysis unit in the University of Iowa hospitals and clinics. And the items that are marked, shown in blue, they correspond to the 9 dialysis chairs. And at the center of the room is a nurse's station where healthcare professionals congregate in between care provided to the patients. And in this study, we are primarily interested in figuring out if there are changes we can make to the architecture of this dialysis unit in order to impact the way in which care flows and therefore impact disease spread itself. And I'll talk quite a bit more about this particular study later on. The third example is the picture on the left. This shows the MICU at the University of Iowa hospitals and clinics. It has about 20 rooms, and it has about 30 healthcare professionals across multiple shifts during a day. And we've conducted several studies in the MICU to understand better hand hygiene behavior and patient care patterns. And a lot of these studies are based on data that we extracted using sensor-equipped badges that were worn by these healthcare professionals, and also using sensors on hand hygiene dispensers. And finally, the picture on the right moves us up one further spatial scale. And this is the entire second floor of the University of Iowa hospitals and clinics. And what you can see in this picture is that we've overlaid the architectural floor plan with the graph. And the shortest path distances in this graph roughly correspond to walking distances in the hospital. So in a sense, we're trying to extract a walking distance metric by imposing this graph. And this metric forms the basis of a lot of the studies that we've performed that ask basically whole hospital questions. And in the beginning, when we first tried to do this, we did this by hand, but subsequently, we've designed some tools that can take architectural floor plans as input, those that are created by CAD software, and then impose these kinds of graphs on top of them and basically extract a walking distance metric based on this. So these were some examples of how we think about space and how we, I guess, are thinking about space at different spatial resolutions. So the rest of my talk kind of is organized as follows. Just like traditional computational epidemiology, our work can also be organized into categories such as inference, modeling, optimization, and prediction or forecasting. But because we are studying HAIs and our focus is healthcare facilities, we often encounter problems that are new that, at least as far as we can tell, have not been studied in the context of traditional epidemiology. Sometimes these problems need new computational methods, and sometimes they lead to surprising or unexpected results. So I'm hoping to share some of that with you in the rest of my talk. And I'm going to focus on kind of the two categories in the middle, the modeling category and the optimization category. So the first part of the rest of my talk will be on kind of a particular modeling study that we did. And the second part will be on an optimization problem that was motivated by HAIs that we worked on and we have some results on. Okay. Moving on. This is the modeling study that I briefly mentioned. The goal here was to reduce MRSA infections among hemodialysis patients. And dialysis patients are extremely vulnerable. They're kind of immunocompromised. They visit dialysis centers typically 3 times a week. And there's usually a long-term vascular access to these patients. And so these patients are quite susceptible to hepatitis B, hepatitis C, and various bloodstream infections. And these bloodstream infections can be quite dangerous. And some of these bloodstream infections are caused by Staph aureus. And so the question basically we were interested in is figuring out whether there are architectural changes that we can make to the dialysis unit that might help reduce the spread of MRSA amongst these patients. The overview of our, approach is fairly straightforward. So we are interested in basically building an agent-based simulation of disease spread. And the inputs to this simulation comes from HCP mobility and interactions with patients. When patient dialysis sessions occur, a model of the MRSA pathogen spread. So these are kind of 3 inputs that inform our baseline model. And then on top of that, we wanted to add some architectural interventions. We basically wanted to figure out how to model architectural interventions, and then these would also be part of the input to our simulation. And in this portion of the talk, what I want to highlight is the pathogen spread model. And so in some sense, that's what I want to draw your attention to. HCP mobility and interactions, we obtained them by doing, about a 10-day deployment of a sensor network in this dialysis unit. This network consisted of static beacons that are shown in these green triangles that are placed in different parts of the dialysis unit. Also, we distributed badges to healthcare professionals. So when a healthcare professional would start a shift, they would pick up a badge from, a box of badges that were available. And these badges send signals every 8 seconds, and static beacons receive these signals and record the ID of the badge, the time of the signal, and the RSSI values of these signals. And using this and using a fair amount of cleanup, we were able to extract XY coordinates for these healthcare professionals at basically 8-second time intervals. And this formed the basis of the HCP mobility and HCP patient interactions that we used in our simulation. Also, for privacy reasons, we did not gather any patient data. And so we had to impute dialysis sessions. So we had to kind of figure out when dialysis sessions would start and when they would end. And we actually used the HCP mobility data that I just mentioned in order to impute dialysis sessions. So for example, the picture on the right here shows the distance of a particular healthcare professional number 3, from the 9 chairs in the dialysis unit. And you can see that just after 8 o'clock, they are extremely close to chair 3 for about 20 minutes or so. And they're relatively close to chair 2 and chair 4, which are neighboring chairs. So from this, we kind of conclude that the dialysis session at chair 3 started basically at 8 o'clock, because typically a dialysis session starts with a healthcare worker spending a lot of time at a dialysis chair. And then there are 3 to 4 hours with intermittent healthcare professional visits. And then at the end of the dialysis session, the healthcare workers will spend a fair amount of time in close proximity to the chair before the patient leaves. So using this, we were able to impute dialysis sessions. And these dialysis sessions are fairly regular. So there are about 3 dialysis sessions per chair per day. And using this kind of domain knowledge, we basically figured out dialysis sessions also. And the next piece is basically the pathogen spread model. And we wanted to do this fairly closely, and we wanted to be fairly true to what is known about MRSA spread. So we looked into some MRSA modeling and MRSA spread literature, and we found a fair amount of work on the dynamics of MRSA spread. And based on this literature, we decided that we would explicitly model pathogen load on surfaces like chairs and clothes and skin, nurses' station, surfaces like this that are in the dialysis unit. And the dynamics of pathogen spread have basically 3 characteristics. Pathogen can be transferred from location to location through touch contacts. Pathogen can grow because an infected patient can shed pathogen into their environment. And pathogen can also decay or die off. And it can also be cleaned. And I guess also hand hygiene is another source of pathogen removal. So this is kind of the overview of our pathogen spread model. In addition to this, once we are thinking in terms of pathogen load, the next thing we basically need is dose response function that basically determines when a patient becomes infected. And we found quite a few studies that also think about dose response functions for different environmentally mediated infections. And here is a table from one of these studies that gives examples of several dose response functions. So basic idea is that these functions will dictate the probability of when a patient gets infected as a function of the load on that patient, pathogen load on that patient. The final piece of this pathogen spread model is the fact that pathogen spread depends on several factors, such as the volume of pathogen at the source, the surface area of contact between the 2 entities that are touching, and also it depends on what's called the transfer efficiency. And so different surfaces, skin versus clothes versus porous surfaces versus non-porous surfaces, these all have different transfer efficiencies. So there have been studies on this as well. So we take this into account also in our model. So we kind of put all of this together, and that's kind of part of our pathogen spread model. And here I'm showing a simulation parameter table, not because I want you to read the actual values, but mostly for you to get a sense of the various aspects of our simulation. So there is a shedding rate, there is die-off rate, there are transfer efficiencies of various surfaces, areas of surfaces, and things like that. So these are all kind of part of our pathogen spread model here. Okay? And now we get to, I guess, the architectural changes that we are interested in thinking about. So one of the architectural changes that we thought about but didn't quite implement because it seemed somewhat hard to do was moving chairs further apart from each other. And because of various constraints in the room and equipment constraints and so on, we didn't really implement this in our model. But there are a few other architectural change policies that we implemented. And one of them is that we wondered if replacing the single nurses station in the middle by multiple stations, thereby creating what you can think of as cohorts of healthcare professionals, where one group would be working with one set of patients and the other group would be working with the other set of patients. And thereby, we're essentially creating a partition of these healthcare professionals. So we considered these types of policies. We also considered a policy where we replaced the current nurses station by a much larger nurses station so that the healthcare professionals would be further apart from each other when they're at the nurses station. And interestingly enough, what we discovered is that the policy that has the biggest impact in reducing MRSA infections happens to be the one that increases the size of the central nurses station. And it seems as though kind of dilution of pathogen because these healthcare professionals are occupying a much larger space in the center, seems to be quite important here. And the other surprising, or at least to us, it was a bit surprising, takeaway from this is that reducing healthcare worker contacts could actually lead to an increase in infections in this model. And this is a bit of a cautionary tale, I guess, because in most models of disease spread, you would expect that as you remove edges from a network, that monotonically decreases the spread of infection. But that's not quite the case here, because what happens is that extra edges, extra contacts have a way of spreading the pathogen that then leads to its dilution, and then dilution, especially if pathogen can move onto surfaces that are subsequently cleaned. This, of course, reduces the load of pathogen on patients. And so this is one of the interesting findings we had. And I guess this kind of emphasized the importance of the model itself in leading us to, these kinds of findings. And I guess if we had not modeled MRSA in this particular way, we might not have, reached these conclusions. So I guess that's one of the takeaways we had from this study. Any questions? I guess I'll now move on to the next study. So,
Sriram, just one quick question. How robust were these findings, right? I mean, are they with a basic model of shedding or exposure would change this? So the reason is the very rather important statement, right? Doubling the surface area for nurses reduces the infection count. The first counterintuitive one is even more interesting. I just want to get a sense.
So these findings are pretty robust to variety of parameter values within this model. Meaning, so if we change the transfer efficiencies, there are a number of parameters that we use. So, for example, here they were robust to different dose response functions, things like that. So there was quite a bit of robustness within this model. I guess the question we are not quite sure about, and there's a bit of a disclaimer, is whether the model itself, it's not clear how valid the model itself is. We've kind of extrapolated from this model from fairly small scale studies. So with respect to this model, our results seem fairly robust, but whether the model itself, the validity of the model itself is not quite clear to us. And that's one of the things we're interested in figuring out what sort of studies we can do kind of in the future that are relatively low cost in terms of swabbing and things like that are relatively low cost, but that might help us validate aspects of this model. So in a sense, we want to extract hypotheses from this model that can maybe be validated by subsequent studies.
Okay, thanks so much.
Yeah.
I have a quick question on the result part.
Yeah.
Can you show the slide there? My question is for the infection count here. Can you tell me what the 3.5 mean there? Like, is that the percentage, or basically I want to know how bad is your baseline?
Yeah, so these are actual numbers. So the 3.5, etc. means, there were 3 people who got infected over the course of 30 days.
How many people, like the total number of people?
The total number of people, basically, see, there are about 30 sessions. So I'm kind of blanking on this, but maybe 15, 16 people.
Okay,
so that's the number of patients.
So out of 15 people, there are 3 people they got infected within
That's
30
right.
days?
That's
okay,
right.
the rate is pretty high. Like
rate is pretty high.
Right, 20%. So can I say, so if the cost is not a factor, like we could even suggest people to do this dialysis at home instead of in a hospital then? Like 20% of infection rate is pretty high.
Yes,
Okay.
I think the answer is yes. I mean, I'm not completely, sure what other trade-offs there are between, dialysis at home versus dialysis at a dialysis unit. But, taking those other trade-offs into account, yes, this is fairly high. Yeah.
Okay, thank you.
And actually, there's one last thing I wanted to say before I move on to the next study, and that is in work that involves Anil and some others, we've kind of abstracted this, this particular, what we are now calling load sharing model, to more general contact networks. And the equation that you see at the top, it may be a bit hard to read, but it basically describes the load at an entity Y at time t plus 1 as a function of loads at time t. There are, 4 terms in the equation that you see on the right. The first term is the die-off term. The second term is outgoing because of contacts. There is some transfer of pathogen that leaves this particular entity Y. And then there is some pathogen load that's incoming through these contacts. And finally, the last corresponds to this entity shedding pathogen. And this is stochastic because it depends on the dose response function I mentioned earlier. So in a sense, we can take this model that I talked about just with respect to the dialysis unit setting, and we can kind of extrapolate it and use it on top of an arbitrary contact network. And that's what we did in some recent work. And many of the questions that one can ask about, say, the SIR model on contact networks and so on, can also be asked about this model imposed on contact networks. And that's what we've done some work on in that area. Now I want to talk about the optimization problem that I mentioned earlier. So the problem here that we're interested in here is motivated by some observations that we had from the MICU, Medical Intensive Care Unit, that basically showed that there was some naturally emerging cohorting behavior amongst healthcare workers. What I mean by that is, based on mobility patterns, we noticed that healthcare professionals tended to deliver patient care in nearby rooms, as opposed to rooms that are randomly placed in the unit. I mean, there are not too many rooms in this unit. There, as I mentioned earlier, I think there are about 20 rooms in this unit. But even within those rooms, there was what we felt was kind of naturally emerging cohorting behavior. And we also did some simulations and came away with the conclusion that this, what we call naturally emerging behavior is providing some kind of protection against disease spread because there was some clustering and cohorting going on. And this motivated us to ask the question, is this something we could do more deliberately? Could we actually impose a certain kind of cohorting on healthcare professionals? Basically, could we cluster them into these bubbles almost as a preventative measure so as to minimize disease spread, but keeping in mind the fact that we also don't want to degrade patient care, and we also don't want to increase load on healthcare professionals. So this is kind of the high-level description of our problem. Here is a toy example that might illustrate the problem a bit better. So on the left is what we call a visit graph that shows visits of 6 healthcare professionals who are shown at the bottom. And they visit rooms, 4 rooms that are shown at the top. And on the right, you see what we call a rewired graph that's obtained from the visit graph on the left. And we here try to rewire edges of the graph so that most of the edges in the rewired graph remain within the 2 bubbles that I've shown. And of course, the goal is that we want most of the care to happen within these bubbles. But we also want to take into account the fact that not all of this care can be rewired. For example, in the graph on the right, you'll see that healthcare professional P4 is providing specialized care, and that person's care cannot be rewired. They are the only ones who can do this. And so we want to allow this kind of flexibility as well. We also want to take into account costs associated with this clustering and rewiring. We want to make sure that the demand that exists in the original graph is met in the rewired graph. And we also want to make sure that HCPs are not overloaded. And so these are some of the costs that we want to take into account while doing this rewiring. Here is an illustration of our methods applied to the actual UIHC contact network from the MICU. So on the extreme left is the baseline visit graph. And this is based on 1 day of fine-grained data collected using our home-built sensor system. And using these data, we can locate these HCPs quite accurately in the MICU, every few seconds. And the three figures on the right are obtained by, doing this so-called bubble clustering that, we are interested in doing. And orange nodes that you see in the inner circle are rooms. The blue nodes that you see on the outer circle are nurses, and the green nodes are physicians. We assume that the nurses can be clustered, whereas the physicians can't. The assumption here was that physicians may be providing more specialized care, but this assumption is not critical to our methods. Who provides specialized care, who doesn't provide specialized care is part of the input, so we can always change this. And if you compare the figure that you see on the right with the leftmost figure, you can clearly see the effects of bubble clustering into, 5 bubbles. The figures are a bit misleading because they don't quite convey time durations. The edges from nurses, the blue nodes to the orange nodes, are quite heavy because nurses spend a lot of time caring for patients relative to physicians. So the red edges are quite light, but that's not shown quite in this figure. Okay. Now let me actually talk about the problem a bit more precisely. So the input to our problem is we're given a bunch of healthcare professionals, a bunch of locations. We're given this healthcare professional mobility log. We're also given healthcare professional types. And so basically this kind of rewiring or substitution can only happen within these types. We also assume that a subset of these healthcare professionals have no substitute, so they can't be rewired. We also have locations partitioned into 2 types, those that can be rewired and those that can't be rewired. There's a metric space imposed on top of this set of locations. And we also have patients or residents who are occupying these rooms. And the results that we obtain finally, they come from 3 facilities. The UIHC MICU, that's the figure that's shown on the left. But along with that, we also instrumented a couple of long-term care facilities in Atlanta in the summer of 2019. And so we use these methods on the data that we obtained from these long-term care facilities as well. And if you focus on the long-term care facility that you see at the bottom right, you'll see that while there are a bunch of patient rooms, there are also a few common areas where HCPs, have their lunch or, congregate when they're not caring for patients. And these kinds of areas, we might say that we don't want to cluster those areas because the understanding may be that in these common spaces, healthcare professionals don't want to be segregated. So our problem statement kind of allows us the flexibility to designate some areas as areas that will be clustered and some other areas that won't be clustered. So here is one more description of the inputs, but with more detail. So you can see the number of locations, the number of healthcare professionals, things like that from these 3 settings. And here is the formal problem statement. So we're given this visit graph, we are given the healthcare professionals, we're given locations, we are given a positive integer k, and we want to cluster the healthcare professionals and the locations into these k bubbles. And we want to create this rewired visit graph. The goal, of course, is to minimize infection spread. But at the same time, there are several costs that we want to focus on. And these costs include unmet demand. So we want to keep any demand for patient care that's unmet. We want to keep that as small as possible. We want to keep excess load on healthcare professionals also as small as possible. And we also want to keep excess footsteps, basically how much healthcare professionals have to walk in order to get from one room to the next room. We want to keep that as low as possible also. That's pretty important for healthcare workers. And from a computational point of view, this problem, as stated, is intractable, but we formulated it as an integer linear program. And we were able to solve this integer linear program for all three settings because the largest ILP that we got from these three settings had 850 variables and about 7,200 constraints. So we were able to solve each of these ILPs. And the way we evaluate these solutions is we run baseline simulations of disease spread on the visit graph, but then we also run what we call rewired simulations by rewiring the visit graph using the solutions that we get from our ILP. And then we compare infection counts and costs as well. And here are a few, charts showing our results. So one takeaway, of course, is that as we increase the number of bubbles, infection spread falls. And this shows this for this result is for a particular infectivity, but I'll show you that this trend holds for a wide range of infectivities. That's what this picture shows. So basically, the green curve and the green boxes represent the baseline simulations, and the other curve and associated boxes represent rewired graphs. And what we're basically showing is the baseline versus kind of a random rewiring versus a rewiring that we get from solving the ILP. As I said earlier, we also want to pay attention to various costs. What I'm showing in this table is that if we don't pay any attention to the costs, that is, we basically allow the costs such as unmet demand, excess load, excess footsteps. If we don't place any bounds on them in the ILP, they can become quite large. So for example, the box I highlighted in the left table here basically is saying that in one of the long-term care facilities, these healthcare professionals had an extra load of about 3.5 hours per day. And as a result of all the rewiring that we did. So this basically showing us that it's really important to actually pay attention to the costs as well and explicitly try to keep them down. And that's what our final results here show. We're able to use our ILP to explicitly force these costs to be low, while at the same time keeping these infections relatively low. So I guess the takeaway from this is that it's possible to design clustering of patient care into these bubbles so that infection spread is minimized, while at the same time, these costs that we want to keep in mind to patient care and loads on healthcare professionals, they're also relatively low. So I guess we think of this as maybe proof of concept because we basically solved this problem, assuming that we had full knowledge of patient admissions and various other data that is only available in real time. So in our current work, we are, thinking about the online version of this problem, where these assignments of patients to bubbles needs to happen as patients arrive and as they're discharged, and patient demands may change. Some patients may become quite sick, and as HCP staffing may also change. So this is an online problem augmented with some learning. So as we get more information, we, learn more about patient demands and patient length of stays and things like that. So we've proved some worst case hardness results. And as described, this problem seems pretty hard. But on the other hand, the data that we have seems quite far away from worst case. So it seems like our next step should be thinking about how we can model this data so that we're designing algorithms that are more realistic and adapted to the data that we actually have, and maybe try to prove worst case guarantees for these kinds of data models. Okay. So with that, I'm going to conclude, and I have maybe a few more minutes to take questions. Thank you very much.
Thanks, Sriram. Really nice talk. So there are all these other elements like people, visitors, and other kinds of staff. Do you think they have a role in this, or like this cohorting, like this clustering, you expect will maybe include that as well?
This study was done in the MICU where visitations are fairly restricted. So, our kind of working assumption is that at least for studies in the MICU, maybe visitors don't play a significant role. So that's one part of your question. And you also mentioned other staff. Now, there are kind of janitorial staff. There are also staff that provide other sorts of care, for example, food services and so on. But the relative amount of time that they spend with patients is quite small. So our working assumption there also is that their impact on disease spread will be relatively low, but it's not something that we have data for, and it's also not something that we actually evaluated. This is, in some sense, we've kind of assumed away the impact of those kinds of professionals. Yeah.
Thanks.
So I really like the talk. I liked your articulation of the scales, Sriram, because I think you've gotten it down from a single table to hospitals, building itself, which I think captures the story well. The reason I'd asked about the robustness is it's such a complicated problem in some ways internally, and there's so many transmission pathways. I'm trying to see if we were to make policy changes in the hospitals, how can we convince the administrator that this is the way to do this? I bring this up because our colleague Amy, who probably is not online today, has been studying issues. She has got what's called a sync lab. She found out that the sinks in the patient rooms are actually rather important players in the transmission of some of these MRSA-like pathogens. I don't know how one would do such a robustness study that, you've captured all the pathways are not in the first place and the models are right. So any thoughts on it? Because I think this is the right sort of representation to work with.
Yeah, I'm not sure I have, particularly, deep thoughts about that. That's a question we grapple with a fair bit. Yeah, whether, we've kind of captured all the important transmission pathways or not kind of is definitely the question here. I mean, while I don't have an answer to the question, I'll just mention that even what happens outside healthcare facilities is pretty important for HAIs. So we've kind of expanded our scope to outside the hospital, and we also have some results on hospital transfer networks. So basically, patients getting transferred from one hospital to the other, and how these transfers can also lead to increase in HAIs. So that's kind of one direction outside the hospital direction we've gone in. We've also done some recent studies that show that there's a fair amount of community spread of infections such as CDI. So, for example, I talked about this patient who gets a CDI infection, and often patients don't get infected while they are in the hospital. They end up going home and they get infected subsequently. And we've noticed that there's a non-trivial amount of household transmission of CDI, especially associated with prior hospitalization of someone else in the family. It increases the risk of other people in the family. So there are these other pathways also, and how to, I guess, combine these different pathways is the big challenge we have. Because each of these studies kind of focuses on some subset of pathways. So how to kind of think about all of this in a more, I guess, cohesive manner, it's not quite clear to us yet.
Yeah, thanks. Because in the end, if we end up putting strong interventions on a pathway that only contributes, let's say, 10% to the overall transmission, then maybe it's not the right pathway, right? You would think. But I'm not saying yours doesn't. In fact, I think this model is actually the right way to think about it. It just needs this extra thought, which I think looks like you're grappling with anyways. It's an easy question to ask. I realize it's hard. And so my question's motivation is because I was struggling with it myself, and I was hoping to get insights from you.
Thank you for the great talk. So this is regarding the clustering. So have you looked at structural perturbations to the network which you get after clustering and how it affects the spread of the disease? So what I mean is, let's say you have clustered the population into subpopulations and there is little interaction across clusters, but it's possible that people don't follow this clustering and there could be some perturbation in this network based on this behavior. And even a minor perturbation could lead to a less effective solution. So that's the genesis of this question.
Yeah, it's a good question. I suspect this clustering is robust, or I think the degradation, I suspect, would be fairly smooth. As we kind of increase violations of this clustering, but I'm not sure because we haven't done it ourselves. So yeah, so that's one answer at one level to your question. We do allow some number of healthcare professionals and some number of locations to be outside any of this clustering because it's just not feasible to place certain people in bubbles and certain locations in bubbles. So in a sense, there is already some amount of some pathways across bubbles via these people who are not in any clusters. And so some of that is already there. But I guess your question is, if we just think of this clustering as not quite prescriptive and, healthcare professionals are allowed to, violate them a little, then how? Yeah, so I'm not quite sure. But actually, it's a good question because, we've thought about it in the following context. While unmet demand, we can keep it quite low, we can't make it zero. So in other words, there is a little bit of demand from patients that goes unmet as a result of this clustering. So we've talked about whether, when there is this unmet demand, why not use healthcare professional from a different cluster to provide this unmet demand as it arises. So since this unmet demand is small, there'll be a small number of edges that will go across these bubbles in order to satisfy it. So I think we can think about that some more in that context and kind of ask this question.
Yeah, thank you.
Again, thank you, Sriram, our speaker, for a wonderful talk. And thanks everybody for joining us today.
Yeah, thanks everyone.
Okay.